Good morning. My name is Joan Pator. I'm a professor in the School of Nursing and director of the Institute for Healthy Living and Chronic Disease Prevention here at UBC Okanagan in Kelowna. Before we begin, I want to respectfully acknowledge that UBC Okanagan is situated on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation and its people. I also want to acknowledge that some of you might be joining us from many places outside this region, both near and far, and take a moment to acknowledge the traditional owners and caretakers of those lands as well. I'd like to welcome you to the 10th annual Okanagan Embrace Aging Month and thank everyone for joining us today. It's been a really incredible 10 years of hosting Embrace Aging by us at the Institute here for Healthy Living and Chronic Disease Prevention at UBC-O, but also with our partners, Interior Savings and Credit Union and Interior Health. Just to let you know that UBC Okanagan joined the global network of age-friendly universities, formalizing its pledge to make UBC-O more accessible, intergenerational, and committed to research programs that are informed by the needs of an aging society. If you want to know more about the Age-Friendly University Initiative or have suggestions for us or would like to get involved, please contact the Aging in Place cluster. And you can reach them by aging.inplace, all one word, at ubc.ca. Aging, as I mentioned, Embrace Aging was launched 10 years ago to celebrate and raise awareness about positive aging. And once again, this month, we've organized a number of educational opportunities and events during the entire month. And as many of you will already know, these sessions are designed for everyone, young and old alike, and have focused on a variety of topics related to healthy aging and ways to improve quality of life among seniors and family caregivers and really everyone. You do have a closed captioning box that might appear on your screen, and you can move it around, and you can also turn it off if you like with the hide caption button on the menu bar. And just a little bit of housekeeping: questions can be typed in to the comments box for the speaker, and we will address those at the end of the presentation. This event today is brought to you with the support of Embrace Aging Month. And today I'm really delighted to introduce our speaker, Isobel Mackenzie, the Senior Advocate from the Office of the Senior Advocate, Province of BC. Isobel took up this position 9 years ago as Canada's first Senior Advocate. And since then, she's been a very steady voice for BC seniors. She brought to this position over 20 years of experience listening to seniors talk about their concerns, and she continues to do that, and I think we'll hear some about that today. And in this position, she's been able to help us build a better system of support for seniors around the province by convincing policy members to provide the resources to implement these great plans. So without further ado, I welcome Isobel Mackenzie. Thank you for joining us today.
Thank you very much, Joan. My pleasure, and welcome to all of you. I am speaking to you from the ancestral lands of the Lekwungen-speaking people of the Songhees and Esquimalt First Nations here in our provincial capital of British Columbia in Victoria. So I'll start first just by giving a little overview. Let me get my cursors working. Oh, we tested this out, and there we go. Just want to talk a little bit about seniors in British Columbia. So in this last census, the number of people aged 65 and over in BC pushed over the 1 million mark. 1 out of 5, or 20% of BC's population is 65 and over. But as you can see by the map, it's not an even distribution throughout the province. And this will actually be of interest to you in the Okanagan, where actually you have about 25%, or 1 out of 4 people are age 65 and over in interior health. And even within some communities within the Okanagan, it will be even higher than that. And we have the same thing over here on Vancouver Island. We have quite a cluster on the central part of Vancouver Island around the Qualicum area. It's sort of like a version of the Okanagan, of that sort of ring of retirement around the Kelowna area. We find that on the island around the Qualicum area. And then when you look in Northern Health, which is our youngest population, you find it's only 15% that are age 65 and over. And even in Fraser Health, which is a very young community, high immigration community, as many of you will know, again, only 16%. And even in the Vancouver coastal, it's not even quite at the provincial average. So this presents challenges when you deliver programs and services from a provincial perspective for seniors, because it doesn't look the same in all parts of the provinces, in all parts of the province. And part of it is just as your proportion of the population that needs the services and supports is larger, for example, in the Okanagan or here on Vancouver Island, the workforce to provide those supports is proportionately smaller as well. So I think we're learning more about it's not just the cost of these services, it's finding the people that we need to deliver the services. And it's more challenging in those areas where we have larger seniors populations, which is also the areas where we're seeing a smaller proportion of working age population and a smaller proportion of our immigrant population. So where seniors and how they're living is also interesting to look at. And I think that this is an important part of Embrace Aging and looking at healthy living, because the vast majority of us are actually going to live in our own homes for the entirety of our life. And we're going to be pretty healthy actually for most of those years. So if we look at everybody 65 and over, 95% of people live independently, meaning in their own home. About half live in a condominium or a townhouse, and about half live in single family homes, but they're living independently. Even at the age of 85 and older, so this notion that we're going to go from living independently to living dependently in a congregate setting actually is not really borne out by the data in terms of what's in store for most of us. Over 7 out of 10 people 85 and over, 77%, so almost 8 out of 10 of people 85 and over are still living independently. And that number went up a little bit in the last census. So we're living longer, we're living healthier for longer, which is what you want to see, and we're living independently for longer as well. And more of us are proportionately living independently. So if we look at, okay, what's happening with the 23% who aren't living independently at the age of 85 and over, about 9% are living in what we think of as assisted living, retirement home, seniors independent living. It has a bunch of different names and it can look a little bit different, but the general theme that most of you will be familiar with is you get your own place, usually a little kitchenette, oftentimes a bedroom, in addition to a living space, and you're sharing a meal, at least one meal a day, sometimes two, with other people. And you might have some services if you need them, and there's people living in these places who need no personal care services. They are there simply to have the enjoyment of other people and to have the meals cooked and served for them. So that's where about 10% of people 85 and over are living. 13% of people 85 and older live in long-term care or nursing homes, or residential care facilities. There's different names we use, but it's where you have 24-hour care available. That number's gone down. It used to be about 15% before the last census. So I think, while we talk a lot about long-term care, and there's a focus on it, and certainly there's a need for that focus, it is important to remember that the vast majority of us will never live in a nursing home. And in fact, the vast majority of British Columbians don't actually have any family members living in long-term care. Most of us will live independently in our own homes. A lot of talk about housing across the age spectrum. The housing issues for seniors are a bit different. Basically, by the time you turn 65, you're either a homeowner or you're not. You're not going to become one for the first time in your 70s. Home ownership is higher, as you would expect, among people 65 and over. About 80% are homeowners. It's interesting, if you look at the population below, like the total population, it's about 70% Actually, that might be down to about 67% now. So it is higher for people over 65, but not drastically higher than the overall population. We may see that shift a little with the changes in our housing market in the last 10 years and certainly in the last 5 years. But and you find that in the more rural parts of British Columbia, homeownership is higher, and in the congested urban areas like the west end of Vancouver, it's lower. You might have about 25 to 30% of people 65 and over being renters in those areas. So the issues for the seniors who are renters are profound. For seniors who are homeowners, the issues around housing are a little bit different. Living alone. So we hear a lot about isolation and loneliness. Well, when we hit the age of 65, about a quarter of us are already living alone, either divorced, early widowed, or never married. So as we go through the aging process, if we are accustomed to living alone, that looks much different than if we have been with our partner, our spouse, well into our 80s and 90s, and then our spouse predeceases us. That looks very different. You can see that at age 85 and over, the majority actually still do live with someone, and the majority of those people are still living with their spouse. As inevitably, as we know, one spouse will predecease the other, but that is tending not to happen until we're well into our late 80s and early 90s. At the age of 65, 88% of us have a driver's license. So the vast majority of people enter their retirement years with that sort of freedom and spontaneity that comes from, I want to go somewhere, I just get the car keys, get in the car and go. As we age, the ability to drive decreases. And so at age 85, it's still over half, but not by much, have a driver's license. And if you look at everybody over 85, you can see it drops to 40%. So obviously, and the challenge, it would be okay if your life went along a trajectory of complete independence, driving until I, walked through the care home and turned in my keys. That's not what happens. What happens is we're still living on our own. We're still living independently. We still want to get out and about, but we no longer have that either confidence for a lot of people or ability. Usually it's related to eyesight, to be able to drive. And what does that look like? And how are we going to plan for that? And how are we going to adjust to, even when there are robust transit systems, for example, in big urban areas, there's still that requirement to plan for everything that we didn't have before when we had that freedom of driving. And so that is a challenge that we are going to face. And the median income of seniors. So I think it is surprising to many people to learn of the low incomes of a large number of seniors. So the median income, which means half of the people earn above this amount and half of the people earn below this amount. The median income for a senior in British Columbia is $33,000 a year. That is essentially a minimum wage job income. So to put it in perspective, 6% of the labor force works at minimum wage, and 50% of seniors live on an income at or below minimum wage. And a third of them live on the GIS, which means their income is below $25,000 a year. The average income, so that's just adding up everybody's income and dividing it by the number, is significantly higher. It's about $48,000. And when you see that difference between the median and the mean, the average, what that is telling us is there's a small group of very high income earning seniors who are pulling up that income. And the best that we can derive from the data is it is clustered to a large extent in that 65 to 71 age group where you still have a lot of people working. And then of course you do have some very wealthy seniors as well. So it is important to understand that for seniors, particularly those who are not homeowners, there are challenges as as we age. One of the data points, I'm sorry, I thought it was going to be on this slide, was also prevalence of dementia. So, you know, this notion that we're inevitably going to end up in the nursing home, which is not what the data tell us. The data tell us a different story. We're more likely to not land up there than we are likely to. So it is true of dementia. We are more likely to not develop it than to develop it. So if you look at the entire population 65 and over, the prevalence of dementia is 6% of the population 65 and over has a diagnosis of dementia. If you look at the population 65 to 84, which to be fair is the largest bulk of our population, the prevalence drops to 3%. So vast majority of people 65 to 84 do not have a diagnosis of dementia. When you look at 85 plus, it jumps, and arguably dramatically, to 20%. But that still leaves 80% of people 85 and over without a diagnosis of dementia. Now, there will be memory impairment, there will be cognitive impairment, people's minds can, but that's quite a bit short of a diagnosis of dementia, which, if your cognitive impairment is affecting your ability to live your daily life, you in all likelihood are diagnosed at that point. So people will talk about, a lot of people are undiagnosed. Everybody's undiagnosed with whatever they have until they are diagnosed. We walk around with any of the diseases or ailments undiagnosed until we're diagnosed. The issue is, by the time they start to have an impact on you, that's when you get the diagnosis, and that's what's important for us to remember. So when we think about embracing aging, there's much to embrace. We are living longer, we are living healthier, we are overwhelmingly living in our own homes for the entirety of our life. We are overwhelmingly retaining our capacity for the entirety of our life. We may have episodes where our capacity wanes for a reason related to infections or a hospitalization, but most of us are going, overwhelmingly, most of us are going to retain that ability to make those key decisions about our life for the entirety of our life. We are likely, however, to go from driving a car to not driving a car, and we are likely to go from living with our spouse to not living with our spouse. And we also need to understand, for some seniors, for actually quite a few in British Columbia, the amount of money they have, the resources they have available for the costs of aging are challenging. So what are the challenges to healthy aging? Costs. The costs of aging can be significant, and they relate to physical and cognitive function. So if you are a senior and you own your own home, and you get your OAS and CPP, and you have a small private pension, and it doesn't sound like you have a lot of money, you have $30,000, $40,000 a year. First of all, you're in the top half. You can defer your property tax. If you're healthy, life actually can look okay. However, if you are a renter, if you start to have physical challenges, if you have medication costs that aren't fully covered by fair pharmacare, that can all look very, very different in terms of your ability to enjoy your retirement. The geography, where you live, and this is, I think, underappreciated by people who live in urban environments. The degree to which your ability to age successfully at home and comfortably at home is going to depend if you live in a city or not, frankly. Kelowna is pretty good. You know, over the last arguably 15, 20 years, there's most things you can now get in Kelowna, some of which you used to have to go to the mainland, to the lower mainland for. Some things you still do, but mostly there's a tremendous amount of services offered in Kelowna now. But when you start going up to communities like Fort St. John or Terrace, or even within interior health, you know, Creston and places like that, you've got significant challenges around the location of the services to support you as you age. Family. The best thing is to have a daughter who's a nurse who lives in the same town. And that tends to be quite a good ingredient in the recipe to successfully age. But we do find that I certainly in my previous career in home care saw that the ability to successfully stay at home with supports depended to a large extent on having a family member fairly nearby, usually in the same town. So in, somewhere in Victoria, not necessarily next door, but sort of, within a 20 or 30-minute drive. That does make a big difference. Oftentimes the trigger for moving into either assisted living or long-term care is triggered by the loss of a spouse and the lack of any nearby family to support. Aging at home, absolutely. There are many challenges to that related to the costs, where your home is located, and whether or not you have family nearby. Fragmented systems. So one of the things, specialization is a good thing in many ways, but what has happened in geriatric care as we've brought specialization within geriatric care, we have left many people bewildered at how to navigate what they need. We're very good at telling people you need, you need an assessment for your home environment. You need an assessment from the physiotherapist. You need to arrange for these things to happen. But people are left bewildered on how to make it all happen. Case management has really morphed into case referral. We refer people to things. So we're great at telling you, you need grab bars. We'll even come in and tell you where they should be, but we don't come in and install them. And that's what a lot of people need. We tell you about how you can order meal services and get all these groceries, but we don't set it all up for you and make it happen. And that's the missing ingredient for a lot of people. And it's a very fragmented system. And ageism, the rights of autonomy and the right to live at risk. And, at its core, it's treating a group of people based on their age as though all characteristics of those people are the same simply because of their age, and that's not true. Risk tolerance is different across the population, and that doesn't change for the population age 65 plus. So there will be people for whom safety is paramount. They will want an environment where there are other people around. They will fear, what if I fall and nobody's nearby? And environments where other people, whether it's in assisted living or whether it's in long-term care, is what is going to bring them peace of mind. There are others, though, for whom they are risk takers and have been all of their life. They understand the risk and they choose to live in their own home with the set of risks that brings with it. And that's what we're not very good at recognizing. The system is very supportive when you make the choices we in the system want you to make, but we're not so supportive when you don't make the choices we want you to make. And one of the differences is, at the age of 35, we don't question your cognitive competency to make risk choices. If we did, nobody would have a motorcycle driving license. What we do, however, when you're 85 and 95, is we question whether you really understand the risks given the choices that you're making. And that is something we are going to continue to wrestle with, and will be very interesting to see as this self-advocating boomer generation starts to creep into their mid and late 80s and 90s, so we're a few years away from that, and the demands that they're going to make around their rights of autonomy is I think going to continue to challenge our system even more than we feel today. So costs of aging, as I said, the median income is $33,000. That number needs 25% of seniors live on less than, that should be 24,000, not 20,000. So one of the things to recognize is that in British Columbia, unless you have a private extended health plan, either because it's part of your retirement package, or you went out and bought one from Sun Life or Great West Life, there's no program. So the lower the income, the less likely you are actually to have a private benefit plan. So if you need eyeglasses, hearing aids, mobility aids, dental care, medications, supplies, there's nothing out there for you other than in the medications, there's spare pharmacare, which actually is pretty good if the medication is covered. Help at home, personal care with home support. If you're on the guaranteed income supplement, you are not charged for it. But if you are one of the 70% of seniors who are not on the guaranteed income supplement, you do have to pay for your home support in British Columbia. And it is actually quite expensive. So a person on $29,000 a year in income would pay $9,000 a year for a 1-hour daily visit of home support for their provincially funded home support program, to put it in perspective. And I'm going to talk about that a little bit more. Home maintenance, help at home. The property tax deferral program is good. Ideally, we would expand that and allow a home maintenance program, home adaptations program, where the costs could be deferred and paid off when the house is sold, ideally as part of the estate, because there is no comprehensive program there. Assisted living. In British Columbia, we do have subsidized assisted living. We don't have very much of it. So the challenge is for a lot of people, they go into assisted living, they pay their $3,500 a month. That doesn't include any care. That gets them their 2 or 3 meals a day, and it gets them their accommodation, weekly cleaning, usually a call bell system, something like that. Any care they need is generally on top of that. And it can quickly add up to equal more than long-term care. If you're in subsidized assisted living, it's 70% of your income. The problem is there's only about 4,300 subsidized assisted living units in all of BC, whereas there's about 24,000 market units in all of BC. It's the reverse in long-term care. The majority of long-term care beds are publicly subsidized. There's about 29,000 publicly subsidized long-term care beds in BC out of a total of about 36,000 in total. So there's about 6,000 private beds relative to our 29,000 publicly funded. So long-term care is affordable in British Columbia to everybody. Most people will get their own room. 80% of our units are single occupancy units. Most of them have a single bath attached or a shared bath with the other unit, but there's not going down the hallway to go to the toilet kind of congregate living. So here's an interesting thing to look at, and this is pretty unique to British Columbia because we charge for our home support. Most provinces don't charge. Those that do, we charge the most. We're the most expensive. So we did this analysis of a person with an annual income of $29,000. So both your home support and your long-term care, your client contribution is assessed based on your income. So the higher your income, the higher your contribution. We picked 29,000. This represents about a little less than half of the seniors population in British Columbia. The cost, the estimated cost for the 1 hour of home support, I'm just to the health authority to provide, would be $14,000 a year. The long-term care cost is $82,000 a year. If we eliminated the regulated fee to the individual, the cost to the health authority would be $14,000 a year. And in long-term care, after we take off the resident contribution, the cost to the health authority would be $60,000 a year. What we do in BC is we take that home support, and instead of costing $14,000, we make you pay $9,000 of that. So it only costs us $5,000. But you can see that it very quickly becomes an economic argument in favor of you as the consumer going into long-term care, because you're going to pay $22,000 in long-term care versus $9,000 for home support, but you're going to get everything. You're going to get your meals, your accommodation, all of your care needs, all of your prescription medications, all of your mobility aids. Everything is covered in long-term care. You have to pay for all of that. in your own home. So I am very, very hopeful. I've been raising this issue for a number of years. I hope at some point, if you say something enough and it makes sense, change will happen. I do hope that the province is going to wrestle with this co-payment, because here is a comparison. So Alberta and Ontario do not charge for home support. If you need it, you get it. We charge. One, I looked at two measures. One was what percentage of our residents in long-term care in British Columbia compared to Alberta and Ontario are what we would call low care needs residents. So they have needs that could be met in the community with home support. It's 13% in BC compared to 7% in Alberta and 5% in Ontario. So it's double what it is in Alberta and a little bit more than double what it is in Ontario. That's very compelling. You know, why do we have these low care need, twice as many low care need residents in BC long-term care facilities as they have in Alberta and Ontario? One of the reasons is because the cost of the home support to stay at home is unaffordable. 61% of our admissions to long-term care in BC had no home support prior to admission. That is also a big missing piece. People who go into long-term care, there can be a catastrophic event that causes that, a mass stroke, a motor vehicle accident. Those are fairly rare. Most people who go into long-term care are following a trajectory of declining health. And what you should see is that as their health has been declining, they've been getting the support at home so that we've reached the point where we've exhausted the ability to care for them at home. And that's why they need to go to long-term care. These data are telling us that we are not seeing that. When 61%, over half of your admissions to long-term care, had no home support prior to their admission, there is a big question mark there. How did we go from no care to total care overnight? The answer is we didn't do that. What happened was that person was living at home without supports. Their family became exhausted. They reached the tipping point. They put them into long-term care. Also, when you look at the graph on the left, it's also telling us that some of those 61% of people actually don't need to be in long-term care. They could be cared for at home, but we're going to charge them so much for their home support, they can't afford it. They can't afford long-term. Everybody can afford long-term care. That's part of the challenge. It's almost as though we do too good a job. If we look at what we've been doing over the last 5 years in BC, what is interesting to note is that the number of clients has increased 6%, the number of hours 5%, so the intensity of service has been reduced a little bit. But our population has increased by much more than that. So when you look at it overall, our rate per thousand of target population, we're down about 13% over what we should be doing. The fragmented system, that is also, I think, a challenge for many people, many different services to coordinate. Every community has a list of programs and agencies. They've all got different names, that some of the names don't actually bring to mind the actual services that are delivered. Our linkage with family physicians is extremely weak. Part of that is the physician community is a bunch of independent operators. They're not all on the same record. How do we make sure that the physician gets notified when there's an admission to the care? How do we connect all that? It's a very, very weak system. And the discharge planning from the hospital, again, is very, very weak. We see when it goes well, it goes really well. But when it doesn't go well, when it falls apart, and usually it will fall apart because there's a lack of awareness of what community supports are out there. They're not well coordinated. There are assumptions made. Families are sort of given the list of what they need to do when they leave the hospital, but we're not there to actually help execute that plan. And that's the missing link that I think we need to see. Family caregivers, without a doubt, they're the backbone of our seniors' care in the province. If the family caregivers all went on strike for a day, our system actually would collapse. Our hospitals would be overwhelmed because people would be sent there, and our waiting lists for long-term care would balloon beyond all comprehension overnight. We lack support. Interestingly enough, one of the things that family caregivers are asking for is simply training. How do I do a proper transfer of my mom or my husband from the chair to the bed or the wheelchair? How do I do the physiotherapy exercises that will help retain balance? We sort of just leave family caregivers on their own to figure those things out. Respite. This will resonate with some of you. Without a doubt, one of the biggest reliefs we can bring to family caregivers, even more than financial supports, although for some that is an issue, is respite from the person they're providing care for. So getting in there and either going in for blocks of time during the day so they can get out of the house, allowing our overnight care, so facility-based respite care, where you can send your loved one somewhere for a week or two to give that sort of respite, and our adult day programs. Unfortunately, we were making some progress on adult day programs. The province had invested in them and had increased capacity, and then COVID came. And our adult day programs were actually all closed for over a year through COVID. And as they started to open up, there was a bit of a tepid approach to reopening them. And I still find that they're opening up more, but we're not seeing the number of days offered that we were seeing before. And adult day programs can be very meaningful relief. I mean, if you are caring for your spouse at home and you can send your loved one for 3 days a week, all day, to a day program, that can make caring for them the difference between I can continue on versus I simply can't continue on. And sorry, that slide, we got that autonomy. I've already spoken about that. So I think I will stop there and open it up to questions, and I'm going to stop the screen share there. Okay, there we go.
Wonderful. Thank you so much, Isobel. That was great. I learned a lot by your statistics there. Amazing. So before we begin the Q&A, I'll just remind people that they can type in their comments and questions into the chat box, and we'd be delighted to read them out to people. And I guess, I might start with one of my questions. Is that, I guess, I agree with you. Family caregivers are really the backbone. I guess I'm worried though, because increasingly most of us don't have close family members around us. So given that they're the backbone, I'm a bit worried about what's going to happen, 5, 10, 15 years down the road. Have people got ideas about how that gap might be filled, or what we might do to start building advocates and caregivers in our networks, I guess?
Unfortunately, I think the phenomenon of the changing family dynamic and how it's going to impact seniors' care 20 years from now, for example, is underappreciated. And I would parallel it to the sort of the muck we've got ourselves in with family physicians is in part a failure to read the tea leaves around the inevitability of not just an aging population, but the changing face of the physician workforce. The prevalence of females, particularly in family medicine, and then just the overall changing attitudes towards work that meant you couldn't replace, if you were modeling your physician recruitment based on one-for-one replacement juxtaposed against population growth, that wasn't sufficient. You almost need 2 to replace 1, right? And all these other changes. I would say that is analogous to our current planning for seniors' care into the future, which is not completely recognizing more of us are going to enter our senior years, first of all, not married, either through divorce or never married. And even if we are married, less likely to have had children. If we did have children, less likely to have had as many of them. And then where are those children living? So, and that one is a bit, looks different depending on the community. So we don't know yet what the impact 20 years from now is going to be around the unaffordability of certain real estate markets. So is it going to mean that, you know, my children are not going to live in Victoria because they're going to go start their life somewhere else? The migration patterns we saw from Europe to the New World at the beginning of the last century, we're going to see from our urban centers to other parts of Canada. We don't know, but we do know fewer children, less likely to be married. So, you know, your first caregiver is your spouse, followed by your adult child. So what I think we have to make sure we have is the staff, the people we're going to need. We're going to need to hire people. So the money is only one part of it. The other part of it is you need the people to hire. So the mistake we made with physicians is we cut the seats in medical school, and then we made it difficult to, you know, all those kinds of things. The good news is the kinds of people, the services we need to support us as we age is not people who need 12 and 14 years of training. You can, we are going to need the people, and we're going to have to recognize how much this is going to cost. There's this big shift happening in the labor market over the last 10 years. I mean, if you look back at what were the high demand, which translates into high paying jobs in the 70s, arguably the 60s, 70s, the 80s, you know, the manufacturing sector, the resource sector, those aren't the in-demand jobs. The in-demand jobs are service jobs, which have traditionally been lower paid. So we're going to have to come to grips with this sort of topsy-turvy phenomenon that's happening in the labor force now, that is in part due to our aging population, needs people to look after them.
Yeah, that's very helpful. Thank you. I have some questions in the chat box. One of them is long-term income or long-term care income tested to determine subsidy? So I guess when you go into long-term care, this person is asking if it's income tested to determine whether you get the subsidy or not.
Well, everybody gets subsidized. So this is the other question I have. So one of the, you know, BC does do some things well. Our Fair Pharmacare program is actually pretty good when you compare it to other provinces. So we'll put that in a box over there. The other thing that we do fairly well is long-term care. BC does a little bit better than most other provinces in terms of our single rooms, right? We have more single rooms than Ontario and Quebec, which is one of the reasons why we had better outcomes during COVID. In every province gives a subsidy to long-term care. BC's is pretty good. I'm not sure if we're the best, but it depends on what you mean by the best. So what we do in BC, if we assess you as requiring long-term care services, you get access to publicly funded long-term care services, right? That is based on a physical assessment of you. Then we do a financial assessment to say, how much will you contribute to the cost of this? We take 80% of your income up to a maximum of $3,600 a month. And that maximum goes up every year by a little bit because it's pegged to an inflationary increase every year. But today it's $3,600 a month. The real cost of that long-term care bed is closer to $7,000 a month. It varies from facility to facility. Government pays all the rest, regardless of how much income you have. So a person maxes out their 80% of income equals $3,600. I think when their income is, last time I looked at something, call it $60,000 a year, thereabouts. Okay. So if your income is $80,000, $100,000 a year, you pay the same as the person whose income is $60,000. Now, if your income is only $24,000, you pay significantly less, right? So it is geared to there's no such thing as having too much money. right? Nobody is going to be told there's no bed available for you, you have too much money. And we want to think about whether that's fair. The other thing is we cap how much we'll take from you. So it's a good parallel. You go into assisted living in the Okanagan. Now, I think you would be hard pressed to find one for much less than $3,500 or $3,600 a month that would give you 2 meals a day and the rest of it. No care. For $3,600 a month, you can have long-term care and everything's provided for you. You pay, your medications are provided under Formula B. You get 3 meals a day. You know, your incontinence supplies are provided for you. I mean, we can debate whether, you know, you want the higher grade of this or whatever, but you get it. In assisted living, you're paying for all of that yourself.
Yeah, we need to fix that, I think.
The financial incentives are not aligned
No,
to the policy outcomes we are trying to achieve. And I have a very, very difficult time getting, you know, people get all caught up in rhetoric about other things. You know, whether it should be private, whether it should be public, whether the waiting, la 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 la. Okay, whoa, let's, you know, cut through all of the hat. Every way you turn, our publicly financed programs are incentivizing you financially to go into long-term care.
Yeah, it sounds like we should be building less new long-term care beds at the moment and putting that money into home support.
Yep.
And we'd be a lot better off and we wouldn't actually need those extra beds. Yeah. So we do have a question from Sandra. At what age can we use pharmacare? Does it happen automatically if we're registered? I'm not sure.
Yeah, that is where BC I think we are the only province that does it for people under 65. So, you know, people talk about a federal pharmacare program. It's not going to really make a big difference in BC. So every British Columbian is covered under Fair Pharmacare, period. What Fair Pharmacare says is that you are expected to pay 4% of your income towards your medication costs. And once you've paid that, it's called your household maximum or family maximum. We will pay everything else. So some people think it doesn't work because they have to pay for their prescriptions. That's because they don't have that high a cost of medications, right? So if you think about someone making $100,000 a year, they're going to have to spend $4,000 of their own money on medications. And then if they have, so the other term that people use is it's catastrophic drug coverage, right? So it's going to make sure that nobody is bankrupted by their medication costs. Everybody can afford it. Now, the challenge is there's a formulary. So your drug has to be so generally these drug programs, wherever you look across the world, no government provides any drug you want totally free of charge. There is generally a combination of there's a formulary and there's some form of copayment. If there's no copayment, there's generally a very narrow formulary, right? So it's not very many drugs. We have a fairly robust formulary. So, you know, you need an antibiotic, most things have a generic version that's covered. You will hear of these extraordinary drugs every once in a while that somebody wants for treatment of a rare disease that are extraordinarily expensive. Those are challenging. Sometimes they're covered, sometimes they're not. And then some people want ordinary drugs, but they want the more convenient version of it that's not covered, right? But overall, anybody born 1935 or later is expected to pay 4%. Anybody born prior to 1935 or earlier, 3%. After 1935, 4%. And the reason for that was when it had to do with when the reason why there's a 1% difference is that the people born 1935 and earlier were the ones who were receiving it for that amount before it was expanded to all British Columbians. So we didn't always have universal coverage. Most provinces only cover their seniors.
Right. Yeah, that's very helpful. So Janice asks, would co-housing, not co-ops, but co-housing based on on a village community within urban centers be a housing alternative for seniors in BC?
Well, I mean, co-housing, I'm smiling because somebody was talking about, I've been around. People come, they put these new names on basically old ideas. So co-housing at the end of the day, we're individuals. What's going to work for one person isn't going to work for everybody. Co-housing is, a condominium kind of concept with like-minded people. And, I think what I would say is that if you can live with other people very close by, and if those other people share common interests with you, that's a better recipe for aging successfully. People help each other out, right? So, co-housing and, get the idea of, all these people with big houses, get roommates in and all this kind of stuff. And it all sounds great in theory. And, there are some practicalities to things. So co-housing, you sort of, well, what happens when how are you going to deal with the person that can't care for themselves? Well, they'll have to move. Well, exactly how are you going to get them to move if they don't want to move, right? These are sort of the same with the roommates. Like, how is that going to work if you have a bad roommate? How is it going to work if the roommate isn't the bad person, but the host is like there's no panacea here. It is basically, I think, what people have to understand, plan. The only thing I can give from my 20 years in home care is decisions made in an emergency are never as good as decisions made before the emergency. Some people struggle because they never think the emergency is going to happen, so they never make the decision, right? So I don't ever want to leave my, home on the, till I absolutely have to. Well, you don't want to think about that, right? And again, people will make their decisions based on what they want and their risk. Some people are going to choose the solitude, the physical beauty of their farm, understanding what that's going to mean as they get older. Others are going to say, no, I'll move into town, I'll buy a condominium, I'll buy whatever, right? It's just understand, on balance of probability, you will likely be able to live independently the entirety of your life. You will likely not be driving, and one spouse will predecease the other. And you will likely retain your decision-making capacity. All of those things may also be not true. You can't predict who is going to develop dementia. You cannot predict who is going to require long-term care. You cannot predict which spouse is going to predecease. You can't predict any of that with certainty. But we make decisions on balance of probability, or at least in my world.
Yeah. Yes. No, I think planning ahead is a great idea. And I know some of my family in Alberta, there was, and I don't know if it's the same in BC, my parents were encouraged to get their name on a list for assisted living, so that, and if their name came to the top and they didn't want it, that was fine. They could decline, and their name then would go, I guess, down the list, or the next person. Is it the same here, that if you're planning ahead, you should get your name on a list for an assisted living place that you might like?
Well, if it's now, the Alberta system for assisted living is better than ours. There's much more subsidized assisted living. First of all, when I started in the old days, when the dinosaurs roamed the earth, we used to allow you to prophylactically place yourself on a long-term care list. And back in those days, we had intermediate care, which was a version of assisted living, right? And then we realized, well, wait a minute, we have no idea what the real demand is, because we've got all these people putting themselves on a list 10 years ahead of so we stopped that. So in BC, there's for long-term care, for any publicly funded service, long-term care or assisted living, you can't put yourself on the list. We put you on the list after we've assessed you. So when we assess you, you go on the list because you need it now, not you're going to need it. Private assisted living out there, most places, there is turnover. And that is what assisted living, most of it is in British Columbia, is private. It's different in Alberta. You will find a place. I mean, you can go and get yourself put on a list. You know, the high-end places, certainly in the Okanagan, you can go and talk to them and, you know, they'll give you, but most people, you know, you're not doing it years in advance. As circumstances change. To be fair, in the last, I would say 5 or 6 years, you know, 5 or 6 years ago, if you had the money and you wanted long-term care immediately or assisted living immediately, you'd find a place. Now, it might be 2 or 3 months waiting, but not years of waiting.
So there's a related question to this. So can seniors choose the facility for long-term care, or is it the first available when needed? I know I've heard some of this in the news.
And this changed, the government changed this in 2019. So the short answer is you can choose. So, and there's also first available bed. So the system we had before said you can choose, but you must take the first available bed, and then you'll be on a transfer list for the place you choose. And if you refuse the first available bed, some would say you go to the bottom and some would say you go off the list. Okay, that changed. In 2019, the regulations were changed, the policy was changed. You can choose up to 3 preferred facilities. Now, you don't have to choose 3. You can only choose, you can choose 1. If you're saying basically I'm only going here or nowhere, we allow that. When, and you're ranked in terms of priority for placement. So the highest priority placement is going to be somebody who's occupying a hospital bed and can't go home. The second highest priority is going to be somebody who is at home, who is deemed to be at high risk. And generally, we might even, certainly in areas like Victoria, we'd be having live-in home support in there. Okay, so when a bed becomes available in the system, we will go to those folks. If there's one of those, we'll go, and they have a right to say, no, I won't take that bed. Okay. Now, if they're sitting in a hospital bed, at some point we're going to say, well, you can't sit in the hospital bed forever and keep turning down these first available beds. So we're going to start to charge you, or we're going to make you go home, or something like that. If you're sitting at home, and a lot of times what you'll see is somebody's at home, the family's brought in a lot of paid help. It's costing the family a lot of money, but they're doing that until the bed becomes available. They can, so a bed, first available bed becomes available, they're offered, they decline, they can continue to pay. And then when the bed becomes available in their facility, they'll be offered it, and they don't get put down the list. And we've measured this, and more people are getting their preferred placement than before this policy was in effect.
That's great to hear. So we have a comment from Pam regarding fragmentation of services. Is there any provincial plan to address this so that the public is able to better navigate through this? When you have to make important decisions, it's very difficult to know what information you need in order to do that. Like, we all need navigators.
Yeah. The short answer is there isn't a plan. It's complicated. I know that's the new, it's complicated, so it becomes an excuse for we can't fix it. There are, in my observation, part of the problem is there are some difficult decisions to make, and people who will be unhappy with those decisions because you've got a lot of different providers out there. There's too many. We need consolidation. We need, you know, there's the voice of the people who say, you know, we do it this way here and it works. And then somebody over here says, we do it this way over here and it works. That's what's led us to the place where we are, right? We need a more comprehensive, and that would arguably require provincial leadership, and people push back on that. You know, provinces push back on being told what to do by the federal government, and communities push back on being told what to do by the province. And there's consequences to that. And the consequence is we see this fragmented system, even within health authorities, right? It looks very in interior. It looks very different down in East Kootenay than it does in the Okanagan.
Yeah.
And it's the same health authority.
Yes. So no easy answer to that yet. No. So we just have to use Google for the moment and hope for the best. But I see that we've run out of time, and this has been a really great conversation. And I want to thank you on behalf of everyone who's joined us today for spending some time with us and bringing us up to date with what's happening in our province related to seniors, and really letting us know that for many of us, and for all kinds of reasons, we can continue to embrace aging for many years to come. So thank you once again. I want to also thank the participants that joined us today for doing that, and I encourage you to attend some of our other events. There's still some events coming up till the end of the month that look really interesting to me. And so I hope that we might see you at some of those events. And if you haven't already checked out the website, OkanaganEmbraceAging.com, I encourage you to do that and register in some of the events. So once again, thank you to Isobel, and thanks everyone for joining us, and enjoy the rest of the day. Bye for now.
Thank you for inviting me. Embrace
Bye-bye.
aging.
Embrace aging, yeah. Thank you.
Like a senior. Okay.